Hello. Yeah. Hi guys. Sorry for the issue. The thing was that what happened was that uh, there was a bit of a internet issue on my end, and because of that, the stream got disconnected a bit. Okay. So we were talking about this particular topic of thyroglossal cyst, and we are going to continue that. Okay. So what I'll do is quickly I'll kind of revise this for you guys, and we'll kind of continue from where we left. Okay. So what did I tell you that thyroglossal cyst? This basically presents as a midline swelling. Okay, so midline swelling, which is basically moving with the degglutination and the protrusion of the tongue. I showed you this as an image. I told you that there is a like a tongue, and from the base of the tongue, what happens is that the thyroglossal duct basically comes down, and when it comes down into the neck, it basically gives rise to the formation of a thyroid gland. And after the formation of a thyroid gland, this thyroglossal duct has to kind of disintegrate. But if at all this particular thyroglossal duct it fails to disintegrate, okay, if at all this particular thyroglossal duct it fails to disintegrate, then what is going to happen? There's going to be like remnant of a swelling, and that is what is referred to as a thyroglossal cyst. Now the most common location of this particular thyroglossal cyst is the subhyoid, that is just below the hyoid bone, and the presentation is that there's going midline swelling, which is basically moving with the degglutination and the protrusion of the tongue. Okay, I hope you've understood. Now for the diagnosis, we have an ultrasound and an FNAC, and the complications, we were talking about the complications, right? So what are the complications? Okay, why so let's kind of talk about that. It is just a subcutaneous swelling, so what can happen? It can easily get infected. So that is one of the important thing. It can lead to the formation of a thyroglossal abscess, and this can kind of rupture and lead to the formation of a thyroglossal fistula and everything. Okay. Another important complication of this is a malignancy. So if at all there is a long-standing thyroglossal cyst, okay, so if at all there is a long-standing thyroglossal cyst, then what do we have? Then we have something which is referred to as a development of a papillary carcinoma of thyroid. Okay, so please try to understand over here. A long standing thyroglossal cyst is a risk factor for what is referred to as your papillary carcinoma of thyroid. Papillary carcinoma of thyroid. Not like every thyroglossal cyst is going to land up into this, but a long-standing thyroglossal cyst, yes, there is a risk of development of a papillary carcinoma of thyroid, and that is why we always have to kind of operate on these particular patients. So what is the surgery which you basically do? So we do something which is called as a cyst trunk operation. Okay, so what you basically do is a cyst trunk operation. So what is this particular cyst trunk operation? In the cyst trunk operation, what do we do is we remove the thyroglossal duct. Okay, so in this, what we remove the thyroglossal duct with the cyst, with the central portion of hyoid bone, with the base of the tongue. Okay, so what do we kind of remove in this? We remove all these particular things: thyroglossal duct with the cyst, with the central portion of the hyoid bone, with the base of the tongue. So these are the things which we basically remove in this particular patient. Okay, so in the cyst trunk operation, we end up removing all these particular things. Okay, I hope you've understood this point. So that is what you refer to as a cyst trunk operation. Now, what you need to understand is that the thyroglossal duct, or the thyroglossal cyst, this is basically a congenital swelling. Okay, so this thyroglossal cyst, yes, this is what is referred to as it is a congenital swelling. But the thyroglossal fistula is always an acquired kind of a thing. Okay, so what you need to understand is that the thyroglossal fistula, this is acquired. This is always an acquired kind of a thing. This is always acquired. Thyroglossal duct, yes, definitely that is what is referred to as your please raise the audio. Okay, is everybody having an issue with the audio, guys? Everybody is feeling that the audio is a bit less. Is it better now? Is it better? The audio is better now, guys, or it's still kind of less only? Okay, I hope the audio is better now. Okay, right? Okay, so yeah, what I was trying to tell you was that the thyroglossal cyst is always a kind of a congenital swelling. It's always a congenital swelling, but the thyroglossal fistula, this is what is an acquired swelling. Okay, so this is what is an acquired swelling. So what you need to understand over here is that a thyroglossal fistula. Okay, so what you need to understand is that a thyroglossal fistula, how does a thyroglossal fistula occurs? So let's assume that there is a patient who is having a thyroglossal cyst, and if at all that particular cyst basically ruptures. Okay, so if at all that particular thyroglossal cyst ruptures, or let's assume that there is a abscess and somebody does an IND over here. If at all somebody does an IND, then also there is a development of a thyroglossal fistula. So the thyroglossal fistula is always an acquired swelling. Cyst is something what is referred to as your congenital swelling. Okay, I hope you have understood this point. Understood? Right. Now, the next topic which we have to talk about is a papillary carcinoma of thyroid. Okay, so papillary carcinoma of thyroid. Now, what you need to understand about the papillary carcinoma of thyroid. Okay, so this is the most common thyroid malignancy. What is this? This is the most common thyroid malignancy. This is also the thyroid malignancy which is having the best prognosis. Okay, so this is the most common thyroid malignancy, and this is basically the thyroid malignancy which is having the best prognosis. Okay, so best prognosis is also what is something which is basically present with a papillary carcinoma of thyroid. Best malignancy and yeah, like a best prognosis and the most common thyroid malignancy. Okay, I hope you've understood this point. Now, if I talk to you about the risk factor, so what is the risk factor for the development of this papillary carcinoma of thyroid? Can you please help me with this? What is the risk factor for the development of a papillary carcinoma of thyroid? The risk factor for the development of a papillary carcinoma of thyroid is radiation exposure. Radiation exposure to the neck. Okay, radiation exposure to the neck. So let's assume that there is a patient who had some kind of a head and neck malignancy in the childhood, and now there has been a radiation exposure to the neck that has led to the formation of a papillary carcinoma of thyroid. So this is one of the important risk factor. Another important risk factor for the development of a papillary carcinoma of thyroid is something what is referred to as your, we just talked about that. What was that? We talked about a thyroglossal cyst, right? A long standing thyroglossal cyst. Okay, so a long standing thyroglossal cyst. Thyroglossal cyst. A long standing thyroglossal cyst. Okay, I hope you are able to understand this particular point. Okay, radiation exposure and a long standing thyroglossal cyst. Now, what you need to understand is that the papillary carcinoma of thyroid is something which is more common in the females as compared to that of the males. Like, is it more common in the males or the females? So it is much more common in the females as compared to that of the males. Okay, I hope you have understood this point. Now, let's talk about the presentation. What do you think? How is going to be the presentation of the patients with this particular papillary carcinoma of thyroid? So the presentation of the patients with the papillary carcinoma of thyroid is that it can come to you with something which is called as a lateral aberrant thyroid nodule. Lateral aberrant thyroid nodule. What do you understand by this particular lateral aberrant thyroid nodule? That there is a kind of a swelling which is not in the midline, which is slightly off the midline. Okay, and there is a like a thyroid nodule which is present. So that is what is called as a lateral aberrant thyroid nodule. And they might give you that this is a swelling, like this is a nodule which is going to move with deglutination. So don't get kind of confused over here. Okay, so if they say that there is a nodule which is moving with the deglutination, it can still be what you call as a this particular papillary carcinoma of thyroid. Are you understand my point? So nodule which is going to move with the protrusion of the tongue, that is what is basically a thyroglossal cyst. But any particular thyroid nodule, it can also move with the deglutination. That is something which you need to understand over here. So that is one thing. Another thing what it can come to you with, it can come to you with an occult thyroid malignancy with early lymphatic spread. Are you understand my point? Occult thyroid malignancy with an early lymphatic spread. This is how the patients can come to you. Are you understand my point? So what do you understand by an occult thyroid malignancy? What do you understand by an occult? occult basically means hidden. Okay, so what is occult? Occult is basically hidden. Okay, so it means that when you basically palpate the thyroid, there is no nodule. Okay, but what you have is, we have a lymph nodes which is enlarged in the neck. Okay, you understand my point? So an hidden thyroid malignancy within lymph node metastasis. Okay, so as you can see over here, that in the papillary carcinoma of thyroid, what we have is a lymphatic metastasis. Okay, so what we have is the lymphatic metastasis is much more as compared to that of your hematogenous mets. Okay, so the lymphatic metastasis is much more as compared to that of your hematogenous metastasis. Please try to understand. So over here, what you basically get is, we get an early lymphatic metastasis. So what you basically get is an early lymphatic metastasis. Please try to understand over here. What you basically get is an early lymphatic metastasis. That is what you need to understand. Now, what do you find on an FNAC? Okay, so for the diagnosis, what you basically perform is an FNAC. So no doubt, FNAC is basically your investigation of choice. And what you're going to find on this particular FNAC? So on the FNAC, what you find is Samoma bodies. Okay, so what are these Samoma bodies? Samoma bodies are your what you call as an inclusion bodies. Okay, so they are your inclusion bodies. They are basically found in this particular patient. Okay, so inclusion bodies, some more bodies, that is what is found. That is first thing. Second thing, what can be found is something which is called as an orphan any I nuclei. Okay, so we can have a some more body, we can have an orphan any I nuclei. What else can you can have? You can have pseudo grooving. Okay, so what we have is a pseudo grouping. Are you understand my point? So on the FNAC, what we have, so more bodies, orphan NEI, and the pseudo grouping. These are the things which you basically find. What is this orphan NEI nucleus? So as you can see over here, this is a cartoon character where the sclera is kind of completely visible. In the similar manner over here, when you kind of look into the slides, what you need to understand is that inside the cell, it is more or less kind of empty. So that is what is referred to as your orphan NEI nuclei. And then there is something which is called as a pseudo grooving. Now, what is this particular pseudo grooving? It's not that visible over here, but the cell membrane is invaginating inside. And when you basically look at it through the cross section, it looks like a groove, but it's just an undulating kind of a cell membrane itself. So this is what is the features on the FNAC which you basically get. Okay, I hope you have understood this particular point. Now, what about the management? How do you manage a patient with a papillary carcinoma of thyroid? So please try to understand the management of these particular patients is total thyroidectomy. Total thyroidectomy plus minus modified radical neck dissection, MRND. Okay, total thyroidectomy plus minus modified radical neck dissection. So this is what you need to understand over here. The management is total thyroidectomy plus minus modified radical neck dissection. So why modified radical neck dissection? Because as I told you that there is a risk that the early lymphatic metastasis is a feature of this. Okay, so if at all there is a lymphatic metastasis, if at all the lymph nodes of the neck are enlarged, then yes, you have to kind of go ahead and do this kind of modified radical neck dissection. So that is what you need to understand. Okay, right? So this is all about the papillary carcinoma of thyroid, which you need to understand. It's a very, very important kind of a thing. I hope you have understood this point. Okay, now let us talk about the retrosternal goiter. Okay, so what do you understand by retrosternal goiter? Retrosternal goiter, what is a goiter? Goiter is basically the swelling of a thyroid tissue. Okay, so what is a goiter? Goiter is basically the swelling of the thyroid tissue. Okay, so what is a goiter? Goiter is basically the swelling of the thyroid tissue. That is what is a goiter. Okay, I hope you have understood this point. What is a retrosternal goiter? When that particular thyroid tissue swelling is basically present in the mediastinum, just behind the sternum. That is what is referred to as your retrosternal goiter. Okay, so we say that if at all more than 50%, if at all more than 50% of the thyroid tissue is present in the mediastinum, we say that, you know what, we are dealing with a retrosternal goiter. If more than 50% of the thyroid tissue is basically present inside the mediastinum, that is what is referred to as your retrosternal goiter. Now, This particular retrosternal goiter, it can be of two types. It can be either a primary retrosternal goiter or it can be a secondary retrosternal goiter. Okay, so let us try to understand these particular things. What is the primary and what is the secondary retrosternal goiter? Okay, so let's try to understand that. Okay, so what is a primary retrosternal goiter? Primary retrosternal goiter is a condition when the development of that particular thyroid tissue is happening in the mediastinum itself. That is what is referred to as your primary retrosternal goiter. Okay, so here the enlargement of the thyroid tissue is happening in the mediastinum. This is what is referred to as a primary retrosternal goiter. What is a secondary retrosternal goiter? The secondary retrosternal goiter is a condition when this particular the enlargement of a thyroid tissue, it started in the neck and then it came to lie in the kind of a mediastinum. Okay, so here what you need to understand is that the enlargement started in the neck and then it came to lie in mediastinum. Are you understand my point? So what is the primary retrosternal goiter? It started in the mediastinum itself. Secondary retrosternal goiter, it started in the neck and then it basically came to lie in the mediastinum. I hope you are able to understand this particular point, guys. Okay, right. Now, logical thing is there that if at all there is a primary retrosternal goiter, from where is going to be the blood supply? The blood supply is going to be derived from the mediastinum itself. So in the primary retrosternal goiter, the blood supply is via the mediastinal vessels. Mediastinal vessels. Okay. In the secondary retrosternal goiter, what you need to understand is that the blood supply is predominantly via the neck vessels. So what is happening over here, that the blood vessels of the neck are primarily the one which are basically supplying this secondary retrosternal goiter. Along with this, yes, the parasitic vessels may develop from the mediastinum. Okay, so the parasitic vessels may develop from the mediastinum, but primarily the blood supply is basically from what you refer to as your neck vessels. Okay, so primarily it is basically from your neck vessels. That is what you need to understand over here. Okay, right now. Okay, so this is the basic difference between these. Now, if at all there is a primary, which is more common? Primary retrosternal goiter is more common, or the secondary retrosternal goiter is more common? So please try to understand. The secondary retrosternal goiter is much more common as compared to that of the primary. So around 95% of all the retrosternal goiters are what you refer to as your secondary retrosternal goiter. So that is much more common than your primary. Okay, I hope you have understood this particular point, guys, right? Okay. Now, if at all there is a primary retrosternal goiter, okay, how is going to be the management of this? The management is that you have to kind of go ahead and do a mediastinal incision, or rather the thoracotomy is needed over here. So in the primary, if at all the thyroid tissue is predominantly developing from the mediastinum itself, so over here you have to perform a thoracotomy. Okay, but if at all, let's say there is a secondary retrosternal goiter, so here it can be kind of managed even by the cervical incision or the neck incision. So cervical incision or the neck incision. So the surgery can be done by the cervical or the neck incision as well. In the secondary retrosternal goiter, it can be done by the cervical or the neck incision as well. So this is very important. You have to understand the difference between the primary and the secondary retrosternal goiter. Okay, now anybody can tell me the name of this particular physical sign which is being shown over here? So what is this particular sign, guys? Can you please help me with this? Okay, so what is this? This is what is referred to as your Pemberton's sign. Okay, so what is this called as? This is what is referred to as your Pemberton's sign. So what is this Pemberton sign? Pemberton's sign. Pemberton sign is that when the patient is basically coming to you with the retrosternal goiter, maybe the patient is absolutely fine as patient is sitting in front of you, and when you ask the patients to raise both the kind of hands above the ears or something, what is going to happen? This particular area will become a bit narrower. And if at all this basically becomes a bit narrower, what is going to happen? The blood vessels of the neck are getting compressed, and because of this, what happens is that the patients basically develop the facial plethora. Okay, so patients basically develop the facial plethora, and that is what is referred to as your Pemberton sign. So this is what you call as a provocative sign in order to diagnose the patients as a retrosternal goiter. Okay, so I hope you have understood. This is an important topic of a retrosternal goiter. I hope you have understood this particular point, guys. Okay, now yeah, I'll be kind of moving on to the next topic, guys, but if you want to kind of follow me more, you can kind of scan this particular QR code. This will lead you to my kind of WhatsApp number. If you have any particular doubts, queries or anything, you can just shoot me up, and if at all you have any doubts, I'll be happy to kind of address them. Any in particular MCQ or anything, you can kind of do that. Now, I am also planning to conduct a few more sessions on my particular YouTube channel, so if you wish, you can kind of consider following it, and similar is for the Instagram. This is my Instagram ID if at all you wish to kind of follow me up. Okay, now moving on to the next topic. The next topic which we have is a mammography. Okay, so what is this particular mammography, guys? What is this particular mammography? Okay, so mammography is basically one of the investigations. So whenever there is a patient with a breast lump, okay, there's a patient with a breast lump. If at all there is a patient with a breast lump who is coming to you, what you need to understand is you have to kind of investigate. You have to investigate this particular patient, and you can investigate this particular patient via few ways. Okay, so first is you can kind of go ahead and do a clinical examination. Okay, so you can do a clinical examination. Okay, what else you can do? You can do a radiological tests. So what are the radiological tests which you basically perform in these particular patients? So it is a mammography, there is an ultrasound, there is an MRI. So what are the radiological tests? You have a mammography, then you have an ultrasound, and you have an MRI. So we are going to talk about that. And then there is the pathological tests. They are the pathological tests which you can perform. So what are the pathological tests which you can perform? You can perform an FNAC, you can perform a true cut biopsy. Okay, so this is what is called as a triple screening, or whatever the triple method of examination of the patients or something like that. Triple screen. This is what is the triple screen for your kind of a breast lump. Okay, now we're going to talk about the mammography in detail over here, but yeah, let's try to understand about this particular mammography. So first of all, what you need to understand is that let's assume that there is a patient who is coming to you with a breast lump. Okay, so there is a patient who is coming to you with a breast lump. Okay, so what is the okay, so let's assume that there is a patient who is 20 years old who is coming to you with a breast lump. What is the radiological tests which you are going to use for the screening of this particular patient? Okay, so which radiological test is basically used for the screening of this particular patient? Okay, so can you please help me with the radiological test which is used for the screening of these particular patients? Can you please help me with this in the comment box? Yeah, the answer which you're basically giving is an ultrasound. Okay, the answer which you're basically giving is an ultrasound, and yes, that is what is completely right. So what you need to understand is that the patients who are less than 35 years of age, okay, or the young females, okay, so in the young females, what you need to understand is that in the young females, what you need to understand is that the breast tissue is dense, and because it is dense, what you need to understand is mammography is not useful. Okay, and that is why over here in the young patients, what you need to understand is that we have to kind of perform an ultrasound. For the screening, what we have to perform is an ultrasound. Now, because this is such an important kind of a concept, I'll give you another question over here. Let's assume that there is a patient who is 24 years old and she's basically saying that your mother died of the breast cancer. The mother has basically died of breast cancer. Now she's basically coming to you for the screening. Even she doesn't have any particular lump as well. Okay, so you're not able to kind of having any lump. If I just ask you, what is a radiological test which is going to be used for the screening in these particular patients? Can you please help me with this? Yeah, what is going to be the answer over here? What is going to be the answer over here, guys? So again, like I'm giving you just to kind of re-emphasize this particular topic on you guys. There's a female who is 24 years old. The mother has died of the breast cancer. Okay, MRI or the 3D mammography? Yes, Mike. So yes, the answer is MRI over here. So please don't get confused, guys, over here. Okay, so please understand this particular point. It's a very, very important concept which we are trying to kind of convey over here. In the general population, so what is the difference between the first female and the second female? This is the one who is basically in the general population. In the general population, what you need to understand, the radiological screening investigation of choice for young females is ultrasound. Okay, so the screening investigation of choice for the young females in the general population is an ultrasound. But this is what is a, in this there is a familial breast cancer, familial breast cancer. So here what you need to understand, this is not the general population. Here there is a history of a breast cancer. So this female basically is under the category of what you refer to as a familial breast cancer. So in the patients with the familial breast cancer, with the history of a familial breast cancer, the radiological investigation of choice for the screening is an MRI. Okay, I hope you have understood this particular point. Over here it is an MRI. In the general population it was an ultrasound. Okay, I hope you have understood this particular point. Very, very important concept. Yep, everybody understood this point. Now, let us talk about the mammography. So what is this particular image which you're basically seeing on your screens? So this is what is your popcorn calcification. So what is this? This is what is popcorn calcification. So what is this? This is what is your popcorn calcification. So this is what is basically seen in your, what you refer to as your fibroadenoma. In the fibroadenoma, what you basically have is a popcorn calcification. So this is a mammography, which is being done in the patient, and what you're basically seeing is a popcorn calcification. And what is this? This is what is referred to as your, yeah, so that is what you need to know. It's a benign condition, popcorn calcification. What you basically have is a fibroadenoma. Okay, so what we have is a fibroadenoma over here. Understood? Got it? Right. Now, based on the mammography, what do we have? Based on the mammography, we have something which is called as a BI-RADS. Okay, so what we have is a BI-RADS. What is this BI-RADS? BI-RADS basically stands for Breast Imaging Reporting and Data System. So what is this BI-RADS? BI-RADS is Breast Imaging Reporting and Data System. So what is BI-RADS? This is Breast Imaging Reporting and Data System. Okay, so this is what is referred to as your BI-RADS, Breast Imaging Reporting and the Data System. So what is this particular BI-RADS? Okay, so please try to understand this. What is this particular BI-RADS? So what you need to understand is that whenever there is a patient with a breast lump, okay, so if at all there is a patient with a breast lump, the radiologist is going to kind of report it on the mammography. So this BI-RADS is going to help you standardize things. So this is, you can basically say that it is one of the ways of standardizing the reporting system of a breast lump. Okay, so this is basically a method of standardizing the reporting system of the breast lump. So in other words, if at all there is a patient who is coming to us and saying that, you know what, this particular patient has a report of a BI-RADS 2, we all will understand what are we talking, what are we kind of dealing with over here. Are you understanding my point? Okay, so based on the BI-RADS, what are the categories we have? We have BI-RADS 0, 1, 2, 3, 4, 5 and 6. Okay, so let's kind of talk about that. What is BI-RADS 0? BI-RADS 0 is basically, it basically says that, you know what, it needs an additional investigation or a prior examination. Okay, so this is like when the mammography is kind of not enough to kind of tell whether what is kind of going on over here, because probably some intervention was done in the past or something like that. That's forget about it. That's kind of out of the picture. Let's talk about the BI-RADS 1. BI-RADS 1 basically means negative. What do you understand by negative? Negative means that uh, so what you need to understand about this particular BI-RADS 1, what about the BI-RADS 1? BI-RADS 1 basically is negative. What do you understand by this particular negative? Negative basically means that it has nothing. No positive, no negative, no cancer, nothing is there. Are you understand my point? So that is what is referred to as your negative. So here what we basically perform is a routine screening. So annual routine screening. That is what you need to understand. What you basically perform is an annual routine screening in these particular patients. BI-RADS 2 basically says that, you know what, there's a patient who is having a lump, but that particular lump is benign. Okay, so BI-RADS 2 basically means that there is a lump and that particular lump is benign. So again, there's no suspicion of a malignancy. You don't kind of alter your plan. You don't go ahead with the biopsy or anything. You just continue with the routine screening, annual routine screening. That is what you basically kind of continue with. Now, this is interesting. There is something which is called as a BI-RADS 3. What is this particular BI-RADS 3? This is what is called as a probably benign. What do you understand by probably benign? That there is a high chance of these particular there's a very, very slight chance that it might be malignant, but there is a very, very high chance that whatever the lesion is there, it is more in the favor of a benign category. But you cannot completely rule out malignancy. There is a slight chance that, you know what, the malignancy might be there in that particular lesion. So in this particular scenario, the question which I will ask you is that, will you perform a biopsy? Now the things are in front of you. Obviously, you will say that no, you will not perform a biopsy. But in the exam, what you need to understand, BI-RADS 3, it is a probably benign. Yeah, it is more in the favor of a benign, but there is a risk of malignancy, right? So you might kind of logically think that, you know what, let's kind of do a true cut biopsy. That is not true, because in the BI-RADS 3, all you basically do is the screening, you basically reduce it down from 1 to 6 months. Okay, from annual screening, you reduce it down to 6 months. Okay, so what you basically do over here is that you shorten the interval of the follow-up 6 months. Okay, so you shorten that particular interval to kind of 6 months. That is what you need to understand over here. Okay, so you shorten it to 6 months. Here the risk of malignancy is like more than 0%, but less than 2%. So here the risk is basically between 0 to 2%. This is what is the risk with the probably benign category. Now, in the BI-RADS 4, what you have is a suspicious of malignancy. Now here, you definitely have a suspicious that, you know, whatever the lesion is there, there's a good chance that we are dealing with a malignant lesion. So over here, you have to perform a tissue biopsy. So you are going to perform a true cut biopsy, or whatever you want to call it, like true cut biopsy or whatever, the core needle biopsy, whatever you want to call it. That is what you're going to perform over here, because here you have a good suspicion that, you know what, that this particular patient is having a malignancy. So here what you basically perform is a true cut biopsy. Then what you have is a BI-RADS 5. In the BI-RADS 5, it is highly suspicious of malignancy. So here the risk is more than 95%. So definitely you're going to perform a tissue diagnosis over here. And the BI-RADS 6 is basically biopsy proven. So if at all somebody is basically coming to you with a report, like a true cut biopsy has already been performed and the patient is basically having the report of a malignancy, then that is what is the BI-RADS 6. Okay, now this is something which you need to kind of remember. So what is the BI-RADS 0? BI-RADS 0 is some additional investigation is needed because some kind of an intervention has happened, and just on the basis of mammography you're not able to comment. What is the BI-RADS 1? It means that it is negative. No lesion is there. No benign, no malignant, no lesion is there, absolutely. What is the BI-RADS 2? BI-RADS 2 is benign. It means that there is a lesion which is there, but that particular lesion is definitely benign. There is no risk of malignancy over here, so you do not need to perform a biopsy or anything in this particular patient. What is the BI-RADS 3? BI-RADS 3 is probably benign. So what do you understand by probably benign? That there is a very high chance that that particular lesion is a benign. Okay, there's a slight risk of malignancy. So with your logic, do not say that, you know what, you're going to do a true cut biopsy. What are you going to do? You're going to shorten that particular interval of the mammography. So you're going to kind of perform a mammography every 6 monthly. What is the BI-RADS 4? It is a suspicious of a malignancy. Okay, suspicious of the malignancy. So here you are going to perform a true cut biopsy, or a tissue biopsy has to be performed over here, suspicious of the malignancy. BI-RADS 5 is highly suspicious of the malignancy. Here the risk of malignancy is more than 95%. And over here, you definitely have to perform a biopsy over here. What is the BI-RADS 6? BI-RADS 6 is a biopsy proven malignancy. It means that you performed a true cut biopsy and the patient is basically having the report of a malignancy and the patient is coming to you. That is what is the BI-RADS 6. Okay, I hope you've understood this particular point. So this is like all the things about the mammography which you need to understand. Now the next topic is MRI in the breast cancer. So we've already talked about one particular place where the MRI will be needed in the breast cancer. We usually do not, like, MRI is not done in very cases in the breast cancer, but the indications of performing an MRI in the breast cancer are very important. Okay, so let's kind of walk you through it. So what did I tell you? The first one we have just discussed, that if at all you want to screen, okay, screen patients with familial breast cancer. Very important. Okay, breast cancer. So if at all there is a patient who says that, you know what, my mother died of the breast cancer, or I have a BRCA gene positivity or something like that, in these particular patients, if at all you want to screen these particular patients, then yes, MRI is the radiological investigation of choice or the screening investigation of choice in these patients. What is the second? So to look for the multifocality versus multicentricity. It means that whether this is the breast, right? So we have the 4 quadrants of the breast. What you need to understand, whether the tumor is limited to one particular quadrant or it is basically present in the other quadrants as well. So in order to see whether that particular tumor is localized to one particular place or it is kind of uniformly distributed in the entire breast tissue or something like that, that is what you need to understand about the multifocality and the multicentricity. In order to kind of understand that, yes, you have to perform an MRI. Okay, so that is another important thing. Then let's assume that there is a patient with a breast implant. In the patients with the breast implant, what you can perform is MRI. Okay, so in the patients with the breast implant, what you basically perform is an MRI. Okay, then for scar recurrence. So whenever you kind of operate, let's say you perform a modified radical mastectomy or something like that, what is going to be left behind is a scar. And if at all there is a scar recurrence, whether there is a development of a malignancy in that particular scar, in order to rule this particular malignancy out, okay, if you perform an ultrasound or mammography, you will not be able to kind of distinguish that. In order to look for the scar recurrence, what you have to perform is an MRI. That is what you need to understand. Then what else? For ductal carcinoma in situ, for the DCIS patients, ductal carcinoma in situ, what you have to perform is an MRI, and then you have a what you call as a ductal papilloma. Please try to understand this. These are the 6 important indications of performing an MRI in the patients with the breast. Okay, in the patients which are related to the breast pathologies, these are the 6 important indications of performing an MRI. Screening of the patients with the familial breast cancer, multifocality, multicentricity, breast implant, scar recurrence, ductal carcinoma in situ, and the ductal papilloma. Okay, I hope you have understood this point. Now, what is this particular image trying to show you? Okay, so what is this? This is obviously an investigation. What is this investigation? This is an MRI. What is this? This is what is an MRI. And what is this particular investigation trying to show you? This particular investigation is trying to show you that, you know what, you are having this ruptured breast implant. Okay, so this is what is referred to as your linguine sign. What is it called as a linguine sign? What is this particular linguine sign? Linguine sign is basically the ruptured breast implant. Okay, so this is what is a ruptured breast implant, and this is what is a linguine sign, an important image which can be shown to you occasionally. Okay, so as I told you, for any particular implant, yeah, so you have to kind of look for this. Okay, now, okay, so somebody is asking me a question that, you know what, multifocality, is it malignancy? So both are malignancy, so please try to understand. Okay, so if at all there is a malignancy, right, it can be involving one particular quadrant of the breast, or it can be involving multiple quadrants of the breast. Are you understand my point? Okay, so I understand my point. And even within one quadrant, there can be one single focus or there can be multiple focus. So multiple focus involving a single quadrant or multiple focus involving multiple quadrants. You understand my point? So we are dealing with the malignancy only. So malignancy can be unifocal, or it can be multifocal, or it can be multicentric. I hope you are able to understand this point. Right. So lobular carcinoma in situ is a multifocal. That's fine. Okay. What is the relevance of this? The relevance of knowing this, whether it is involving a single quadrant or not, is whenever you are planning to perform something which is called as a breast conservative surgery. So the whole funda of the breast conservative surgery is that you perform a wide local excision of that particular tumor, and that is possible only if at all the tumor is limited to one particular place. Are you understand my point? We'll talk about the breast conservative surgery, but I hope you have understood this particular point, guys. Okay, so are you understanding? So this multifocality, multicentricity, it is basically malignancy only. Now, for you, it is not that like practical to understand what this particular things mean, but try to understand. If at all there is a malignancy, it can be present at a single focus, unifocal, or it can be present at multiple focal, but within the same quadrant of the breast. So that is what is called as a multifocality. Or it can involve more than one quadrant of the breast. That is what is called as a multicentric kind of malignancy. I hope you're able to understand this point. Okay, got it? Now, and what is the relevance of this? The like the clinical importance of this is to understand when do you perform what you call as a breast conservative surgery and when do you kind of perform a modified radical mastectomy. So based on that, you have to kind of understand this. Okay, I hope you have understood this point, right? Okay, now let's talk about the T&M staging of the breast cancer, because it's again a very, very important topic which you should kind of know. Okay, so let's start with the T stage of the tumor. Okay, so what is the T stage of the tumor? This is basically the tumor, like the tumor and the node and the metastasis. Okay, so what is the T stage? T stage basically consists of T1, T2, and T3, and then what we have is a T4A, T4B, T4C, and a T4D. Okay, so what is T1? T1 is basically that the tumor is less than 2 centimeters in size. And guys, this is one of the T&M stagings which you absolutely must have to remember. There's no way around it. You have to kind of remember that. Okay, so T1 is basically the size of the tumor is less than 2 centimeters. What about the T2? The T2 is basically when the size of the tumor is 2 centimeters to 5 centimeters. Okay, so here the size of the tumor is 2 to 5 centimeters, 2 centimeters to 5 centimeters in size. What about the T3? T3 is when the size of the tumor is more than 5 centimeters in size. Okay, so if all the size is more than 5 centimeters, that is what is the T3. T1 is less than T2, 2 to 5 centimeters, more than 5 centimeters. All are basically limited to the breast tissue. Okay, I hope you have understood this point. Now, what we have is T4. Okay, so what we have is a T4. In the T4, what do we have? In the T4, you have T4A, T4B, we have T4C, and we have T4D. So what is a T4A? T4A is basically, okay, so many students have a confusion between T4A and T4B. Okay, so how do you kind of remember that? Whenever you kind of screw up in your life, what you basically do is you always try to self-introspect first. You basically blame yourself first. Okay, so what is a T4A? T4A is basically involvement of the chest wall. So what is this particular T4A? T4A is basically involvement of the chest wall. Please try to understand over here. What is the T4A? Here there is an involvement of the chest wall. It is involvement of the chest wall. So what is not included in the chest wall? Can you please help me with this? What is not included in the chest wall? Okay, so pectoralis major and minor is not included in the chest wall. Okay, pectoralis major and pectoralis minor is not included. So what is included? Ribs, intercostal muscles, and serratus anterior. Okay, involvement of the ribs, intercostal muscles, and the serratus anterior is included. Are you understand my point? So if at all there is a question which says that, you know what, there is a 4 centimeters of the breast tumor which is involving the ribs, then it is T4A. It is not a T2. And if at all there is a 4 centimeter kind of a breast tumor which is involving the pectoralis major, it is still a T2. It is not a T4A. Okay, I hope you have understood this particular point. T4A is involvement of the chest wall. What is a T4B? In T4B, there is an involvement of the skin. Okay, so here there is an involvement of the skin. So what is included in the skin? So if at all, let's say there is a question which basically says that, you know what, the skin, there is what you call as ulceration, there is ulceration, there is nodule, or there is PAWAN. Okay, if at all there is a ulceration, there is a nodule, or there is a PAWAN, then yes, what you have is involvement of the skin. Now, what is not included over here? If at all the question says that there is puckering or there is dimpling of the skin, this is not included in the involvement of the skin. Okay, the puckering and the dimpling of the skin, that is not included in the involvement of the skin. Why do these things occur? Puckering and the dimpling, or the nipple retraction, okay, or the nipple retraction. Why do these particular things occurs? These particular things occur because of involvement of the ligament of Cooper. Okay, so these things are not included. They are not included in the involvement of the skin. What about the T4C? T4C is when there's involvement of the skin plus the chest wall. Okay, so what is the T4C? There's an involvement of the skin plus the chest wall. Okay, and what about the T4D? T4D is basically inflammatory breast cancer. What is the T4D? It is inflammatory breast cancer. Okay, it is inflammatory breast cancer. Okay, I hope you have understood this particular point. T4D is basically inflammatory breast cancer. Okay, understood? Yeah, so this is about the T stage of the patients with the breast cancer. Less than 2 centimeters, 2 to 5 centimeters, more than 5 centimeters. T4 is involvement of the chest wall. Pectoralis major and minor are not included. What is included is ribs, intercostal muscles, and the serratus anterior. Okay, so these are the things which are kind of included. Then in the T4B, what we have is the involvement of the skin, that is ulceration, nodules, body orange. These particular things are there, but the what you call as the dimpling and skin dimpling, nipple retraction, puckering, these things are kind of not included. Okay, then what we have is a T4C, that is the skin and the chest wall involvement, and the T4D is an inflammatory breast cancer. So these are the things which are basically the T stage of the patients. Okay, now Priyanshi, I'll figure it out. I think there's some kind of a settings issue with the audio, so I'll be going to give you a break in, let's say, 5 minutes or so. In that particular break, I'll figure it out and I'll kind of raise this particular kind of voice. I'll kind of take care of it. I think there's some kind of settings issue, so just bear with me for 5 to 10 minutes. Post break, I'll try that the audio is kind of much better. Okay, now let's talk about the end stage. Okay, so now let's talk about the end stage. So what is the nodal stage for these particular patients? Nodal stages, so please try to understand. This is N1. What is N1? N1 is a single, okay, mobile axillary lymph node. Axillary lymph node. Okay, so the single mobile axillary lymph node, that is what is basically the N1. Okay, then what we have is we have N2. In the N2, what do we have? We have N2A and then we have N2B. So what is an N2A? N2A is when you have a fixed axillary group of lymph nodes. Fixed axillary lymph nodes, that is what is your N2A. What is N2B? N2B is involvement of a mediastinal lymph nodes. Okay, over here there is mediastinal lymph nodes involvement without the axillary lymph node. Without the axillary lymph node, if at all there is an involvement of a mediastinal lymph node, that is what is your N2B. Okay, then what we have is a N3. In the N3, what we have N3A, we have N3B, and we have N3C. Okay, so what is N3A? In the N3A, there is an infraclavicular group of lymph nodes involvement. Infraclavicular group of lymph nodes which are involved. What is N3B? N3B is axillary plus mediastinal lymph nodes. What is N3C? It is supraclavicular lymph nodes. You understand my point? So what we have is N3A, N3B, N3C. Okay, so let's kind of revise the lymph nodes as well. N1 is basically single ipsilateral mobile. Okay, mobile axillary lymph nodes. Okay, so what does mobile basically means? Mobile basically means that the extranodal extension has not yet taken place. Okay, so the tumor is basically, what about the metastasis is there, that is basically confined within that particular lymph node. The cortex of the lymph node has not yet been breached into, is divided into N2A and the N2B. What is the N2A? N2A is basically fixed axillary group of lymph nodes. N2B is basically mediastinal lymph nodes without the axillary lymph nodes. What is N3? N3 is N3A, N3B, and N3C. What is N3A? N3A is infraclavicular group of lymph nodes. N3B is axillary plus the mediastinal group of lymph nodes, and the N3C is the supraclavicular group of lymph nodes. Okay, so this is about the TNM staging of the breast cancer, which is absolutely very, very important. I hope you have understood this particular point, guys. Okay, understood, right? Okay, guys. Okay, so I'll be moving on with the next topic, which is the surgeries of the breast cancer. But for this, what we are going to do is we are going to wait a bit. Let's kind of take a dinner break. You can have your dinner and you can come back by, let's say, 9:30. It's 8:50, like it's approximately 9. So we can, like, the stream will continue. It's not going to be the new video, it's going to be there. The stream will continue. We're going to have a break. We'll meet back at 9:30, and then probably by 11:30 we are going to wrap up this particular session. Okay, so let's kind of meet back at 9:30. Okay, so that's what you're going to do. Okay, by 11:30, 12, we are going to wrap up. Let's meet back at 9:30. Okay, sure. Hello guys, welcome back. Okay, so let's start with the surgeries of what you call as surgeries of the breast. Let's start by talking about that. Okay, so what you need to understand, yeah, I hope you guys are here. Okay, so Mansi, this particular session is basically covering the important topics for the kind of surgery. I'm going a bit slow so that the students who are basically kind of reading it for the first time can grab it. For NEET PG 2024, yeah, it's going to help you, no doubt, but the point is that you have to assess for yourself. If at all you are the one who has kind of already gone through the surgery and read surgery in and out and just looking for some quick revision of the surgery, probably this will be a bit slower for you. But if at all, let's say you have not gone through these particular topics, then yes, definitely it might help you. But yes, I mean, the students, this is mainly targeted for the students who are basically kind of reading the surgery and along the way they want to master these particular topics or something like that. Whether it is the NEET PG students or the FMG students, it really doesn't matter because the topics are the same, as I keep on repeating so many times. Okay, but yes, if at all you're somebody who is going to appear for the exam literally, what do you call, a couple of weeks from now, okay, so that's what's going to be a bit slower for you guys. Okay, so that's the only thing. Okay, for that I will be conducting my one short session on my own YouTube channel on 4th. You can have a look at that. That will be around 6 hours kind of a session. There will be a very rapid revision kind of a thing, which I'll be kind of conducting on my own YouTube channel, probably on 3rd or 4th of it or something. Okay, right. Okay, so let's try to talk about the surgeries of a breast cancer. So let's say if at all there is a patient who is coming to you with the breast cancer. Okay, so there's a patient who is coming to you with a breast cancer. Okay, now what you need to understand is that if at all there is a patient who is having a breast cancer, what are the surgeries which you can subject these particular patients to? Okay, so the thing which you need to understand over here is that you can subject these particular patients to a radical mastectomy. Okay, we do not perform this particular surgery in today's time. We usually do not perform in this. What we used to do is we used to kind of remove the skin, the breast, like the breast tissue. Okay, and first of all, tell me about this. Is my audio better now? Like before the break, many students were complaining of the audio, so that audio is a bit lower and everything. Is it better now? Like, is it, yeah? Is the audio like audible a bit better, or there is still a bit of a lowness in the audio? Please give me a feedback, guys, whenever you can. Just let me know whether the audio is better now. It's good since start. Okay, no issues. Okay, anyway, so I hope it's kind of slightly better now. Okay, that's fine. So what about the radical mastectomy? In this, what you remove is the skin, you remove the breast tissue, you also remove the pectoralis major and the minor as well. So that's very radical surgery. So nowadays we do not perform that. What do you perform nowadays is something which is called as a modified radical mastectomy. And then you have something which is called as a breast conservative surgery. Breast conservative surgery. So these are the options which we have whenever you are dealing with any particular patients of a breast cancer. So these are the options which we have, guys. Okay, are you able to understand this point? Now we are going to talk about this modified radical mastectomy and the breast conservative surgery in a bit more detail. So what we have is a modified radical mastectomy. Okay, so what about this particular modified radical mastectomy? In this, what are we going to do? Obviously, we are going to remove the breast tissue is kind of removed. Okay, along with this, the lymph node stations 1 and 2 are removed. Okay, so what do we remove? We remove the lymph node stations 1 and 2. Okay, now let's kind of understand these particular lymph node stations. Where are these particular lymph node stations present and everything? Okay, so what do we have is we have this particular muscle which is basically referred to as your pectoralis minor muscle. So what do we have is we have a pectoralis minor muscle, and what do we have? We have the groups of the lymph nodes. So there's a group of the lymph nodes which is lateral to this particular pectoralis minor. So you have a pectoralis minor. There's a group of muscle which is lateral to this particular pectoralis minor. There's a group of a lymph node which is behind this particular pectoralis minor, and there is a group of a lymph node which is medial to this particular pectoralis minor. So medial, and there is lateral. Okay, so which is 1, which is 3? So please try to understand the group of the lymph nodes which is lateral to the pectoralis minor is the lymph node station 1. The group of lymph nodes which is behind this particular pectoralis minor is the lymph node station 2. And the group of lymph nodes which are medial to the pectoralis minor, this is what is the lymph node station 3. Okay, so lateral, behind the pectoralis minor, and the medial to the pectoralis minor. So 1, 2 and 3. Okay, so I hope you are able to understand this particular stuff. Okay. Okay, so I'll get back to you. There's a question in the comment box. I'll get back to you. Okay, so did you understand? These are the levels of the lymph nodes which we have. What is this lymph node station 2 referred to as? This is also referred to as a Rotter's group of lymph nodes. Okay, Rotter's lymph node is basically this lymph node station 2, Rotter's lymph node. Okay, I hope you have understood this particular point, guys. Okay, now before I move ahead and talk about the modified radical mastectomy, there is a kind of a question in the comment box. Dimpling and all comes under what stage, sir? Okay, so please try to understand. If I'll explain you with the help of a question. So the question basically says that there is a 4 centimeter breast lump which is having and the patient is basically on examination, the patient is having nipple retraction or the dimpling of the nipple. Okay, so you tell me what is going to be the stage of this particular patient. I hope you're saying that it is going to be stage T2. Okay, so that will depend on the size of the tumor, the primary size of the tumor. Are you understanding my point? On the other hand, if at all the question basically says 4 centimeter of the tumor with the ulceration on the skin, then it is going to be the T4B. Did you get your answer? Okay, Leela Reddy, I hope you got your answer. Got it? Okay, so the stage will be determined by the size of the tumor, the primary size of the tumor. That will determine the stage of that particular tumor. Okay, I hope you understand. Now let's talk about the modified radical mastectomy. Okay, so what are we going to remove? We are going to remove the lymph node station 1 and the lymph node station 2. Now here what do we have is we have a muscle which is the pectoralis minor. Now what you do to this particular pectoralis minor, based on that you have a 3 different types of modified radical mastectomy. Okay, so what do we have? We have a 3 different types of modified radical mastectomy. So what are the types of the modified radical mastectomy? What we have? We have what you refer to as your Auchincloss, Scanlon and Pettis. Okay, so what are the 3 types of your modified radical mastectomy? We have Auchincloss, Scanlon and Pettis. So first is here, let's talk about your Pettis. So in the Pettis mastectomy, what are we doing is we remove pectoralis minor. Okay, so in the Pettis, what we do, we remove the pectoralis minor. In the Pettis mastectomy, you remove the pectoralis minor. What are you going to do in the Scanlon? In the Scanlon modified radical mastectomy, what are we going to do? We are going to cut pectoralis minor. We remove the lymph node station 2 and then we resuture it. In the Pettis, we remove the pectoralis minor. In the Scanlon, you cut the pectoralis minor, you remove the lymph node station 2 and then you resuture the pectoralis minor. But the one which we do most commonly is this Auchincloss. So what is this Auchincloss? In the Auchincloss, what we are doing is we retract the pectoralis minor muscle. What are we going to do over here? We are going to retract the pectoralis minor muscle. We retract the pectoralis minor and then we remove the lymph node station 2. So out of these 3, which is the one which we are going to do most commonly? The most commonly which we are going to do is Auchincloss, or rather most commonly what is done in our daily practice is this Auchincloss. In the Auchincloss, what are we doing? We retract the pectoralis minor and then we kind of remove the lymph node station 2. Okay, I hope you're able to understand this particular. Okay, right? Now let's move on to the breast conservative surgery. But before moving on, I hope you have understood. Okay, Leela Reddy, the doubt which you asked, I hope you have understood. If you have not, just put your kind of thing in the comment box again and I'll explain to you whatever the thing which you have not understood. Okay, I hope you have understood this point, right? Okay, now let's talk about the breast conservative surgery. Now, what is the rationale of performing a breast conservative surgery? Okay, so let's assume that there is a patient. Okay, there is a patient who is basically having a breast carcinoma. Okay, now what are we doing in the modified radical mastectomy? What do? We remove the breast. We remove the breast. Now after removal of the breast, many patients, what they basically opt for is something which is called as a breast reconstruction. Breast reconstruction. Now this particular breast reconstruction, it means that either with the help of a normal tissue like the body tissue or with the help of an implant, what you have to do is you have to reconstruct the breast. Okay, now this has a lot of psychological impact. This has impact on their personal life and everything. So like the patients would like to have their own particular breast tissue. They would like to retain their own particular breast tissue, and for this what we have like over a period of time, the science have kind of come up with the surgery which is called as a breast conservative surgery. Okay, so what we have come up with the breast conservative surgery. Okay, so what are we doing in this particular breast conservative surgery? In the breast conservative surgery, I'll tell you like what are the things which you basically do, but the end game is that the breast tissue is preserved. Okay, so whatever the breast tissue the patient is basically having, that is basically preserved. The original breast tissue of the patient is basically preserved. Are you understanding my point? Now, the argument which you will give is, let's assume that there is a patient. One patient is opting for the modified radical mastectomy. The another patient is basically opting for the breast conservative surgery. What about the outcome? Okay, what about the outcome of these particular patients? Whether the outcome of these particular patients is going to be the same or there is going to be some difference in this particular outcome. Okay, so the outcome can be measured in two ways. First is the mortality. Okay, so please try to understand, in both these particular scenarios, the mortality is the same. The mortality is the same. There is no difference in the mortality, whether the patient basically opts for your modified radical mastectomy or the patient basically opts for your breast conservative surgery. The outcome of the mortality, if you consider mortality as an outcome, that is basically the same. Like it's not going to be any different, and that is the reason why as a doctor we are able to kind of give this particular option to the patient. Just imagine if at all the outcome of the patient, like the mortality outcome of the patient, would have been better in case of a modified radical mastectomy. Just for the cosmetic kind of appearance, we wouldn't have given the option of the breast conservative surgery to the patients, but because the outcome in the form of a mortality is the same, whether you opt for modified radical mastectomy or the breast conservative surgery, that is why we give this particular thing. But there's another way in which kind of we look for this particular outcome. It is the local recurrence. So please try to understand over here the local recurrence. Okay, so what we look for is a local recurrence. So please try to understand the local recurrence is more. Okay, local recurrence is more with modified radical mastectomy. It is going to be more with the modified radical mastectomy, but this doesn't translate into the mortality. I hope you're able to understand this particular point, guys. Okay, understood? I hope you have understood this point. Okay, now let's talk about the breast conservative surgery in detail. So what are we doing in this particular breast conservative surgery? We perform wide local excision. Wide local excision. Okay, so what do you understand by this particular wide local excision? So let's assume that this is the breast tissue, and let's assume that this is a tumor which is basically present inside the breast tissue. What you basically do is, along with this tumor, we remove the rim of the normal breast tissue. So in the wide local excision, what do you remove? You remove the tumor plus the rim of normal breast tissue. How much of the rim do we remove? We remove 1 centimeter. Okay, 1 centimeter is the rim which you kind of remove. Are you understanding my point? So this 1 centimeter rim of the tissue is basically removed with this wide local excision. So here you can say that the margin of the excision is 1 centimeter. Now I've seen so many students asking the doubt, sir, the margin of the like wide local excision in the patients with the modified radical mastectomy, or sorry, with the breast conservative surgery, is it like 1 centimeter or the 1 millimeter? Now, what you need to understand is that there are various studies which are going ahead in which they have considered 1 millimeter as a margin. But by and large, like till date, the proven is 1 centimeter. Now, there's a chance that after 5 years, or let's say 3 years, 4 years, 5 years, 10 years, when we kind of discuss the breast conservative surgery, the margin would be kind of reduced once the studies have proven the test of time. But at this point of time, it is just in the studies kind of a format. So in today's time, what is acceptable? Let's say in the clinical practice, whenever we perform this breast conservative surgery, we take a margin of excision as the 1 centimeter. Along with this, the very important part about the breast conservative surgery is the radiotherapy. We have to give these particular patients radiotherapy. Now, why do you want to give these particular patients radiotherapy? Because radiotherapy will help in preventing the local recurrence. Okay, so radiotherapy is going to help you in preventing the local recurrence. Radiotherapy basically helps in preventing the local recurrence, okay, reducing the probability of this particular local recurrence. Okay, I hope you are able to understand this particular point. Okay, right. Along with this, what you need to understand is that here you may or you may not perform modified what you call as a sentinel lymph node biopsy. Okay, so sentinel lymph node biopsy. Okay, so sentinel lymph node biopsy or axillary lymph node dissection, this may or may not be performed depending on whether the axillary lymph nodes are enlarged or not, or whether the if whether you have a palpable lymph nodes or not, or something like that. I hope you are able to understand this particular point. So breast conservative surgery is a surgery where you remove that, but okay, and what is the, okay, so we'll talk about that indications and the contraindications and everything. But yeah, I hope you have understood this particular point. What are we doing in the breast conservative surgery? We are doing a wide local excision. That what is the tumor is there. Along with that, you remove a rim of a normal tissue. What is the margin which is basically taken? 1 centimeter is taken. We kind of give the radiotherapy to these particular patients. How does radiotherapy help? This basically prevents the local recurrence. Giving a radiotherapy, it prevents the local recurrence. And along with this, what you need to understand is that there is what you basically perform is an axillary lymph node dissection. You perform an axillary lymph node dissection. Along with that, you may or may not, depending on whether the lymph nodes are enlarged or not, based on that, you basically kind of perform that. Okay, I hope you are able to understand this point. Okay, got it? Okay, now what are the contraindications of performing this particular breast cancer surgery? Can you please help me with this? Contraindications. Contraindications for performing the breast conservative surgery. There are 2 absolute contraindications. So what are the absolute contraindications for performing a breast conservative surgery? So the absolute contraindications which we have for performing a breast conservative surgery are pregnancy. Because we have discussed that radiotherapy is a very integral part of this. Okay, very integral part of it is the radiotherapy, and obviously you cannot give radiotherapy if at all the patient is pregnant. That is the first thing. Second is, if at all there is a multifocality or the multicentricity. We have talked about that, right? So one of the indications was that multifocality, multicentricity and everything. So yeah, multifocality and multicentricity. I hope you are able to understand this particular point. Okay, so these are the absolute contraindications. Then there are few of a relative contraindications. So what are the relative contraindications which you have over here? So the relative contraindications are what you can refer to as what are the relative contraindications? Okay, so if at all there is a large tumor size. Okay, so basically try to understand what is the purpose of performing this particular breast conservative surgery, so that the normal architecture of the breast tissue is kind of retained. Okay, so if at all, let's say the tumor size is very big, and if at all you plan to perform a breast conservative surgery, there's going to be a lot of mismatch between the 2 breasts, right? But let's assume that the size of the breast is very big, and then the tumor size relatively is smaller. Are you understanding? So it's a relative contraindication. It's not an absolute contraindication. Tumor size to the breast tissue. Okay, so that is a relative contraindication. Then what else? So let's assume that there was some connective tissue disorder. So let's say there is some connective tissue disorder. Okay, why? Because the efficacy of the radiotherapy will be lesser in these particular patients. Then if at all the patient is basically of a low socio-economic status, socio-economic status. So what you need to understand is that after the breast conservative surgery is performed, we need a lot of follow-up, and in the follow-up you might have to perform a radio like MRI, and radiotherapy is kind of needed. So all these particular things, they cost kind of in what you call as money, right? And it is it is sometimes thought that, you know what, if at all the patient is not having a good socioeconomic status, what is going to happen? The patient is going to be lost to follow-up, and if at all there is going to be lost to follow-up, the chances of recurrence are going to be like recurrence. As we know that it is going to be, oh, I'm sorry, over here I've written MRM, really sorry for this. Recurrence is more with the breast conservative surgery. Okay, so if at all the recurrence occurs, it will not be detected, and this might kind of lead to the mortality in these particular patients, and that is why low economic status is a relative contraindication. I hope you're able to understand this point. Simple funda: patient will not come back, recurrence will happen, it will go undetected, and the patients might have to kind of lose their life. Okay, so that is what you need to understand here. Okay, right, so this is all about the breast conservative surgery and the surgeries of the kind of a breast which we have to talk to you about. Okay, I hope you have understood this point. Now let's move on to the MEN syndrome. What is this MEN syndrome? MEN syndrome is multiple endocrine neoplasia syndrome. So, okay, now this particular MEN syndrome, they can be the MEN 1, this can be MEN 2A, and it can be MEN 2B. Okay, so what is included in the MEN 1? In the MEN 1, what is included is it is a syndrome of 3 Ps. Then what is the MEN 2A? MEN 2A is a syndrome of 2 Ps. And then what about the MEN 2B? This is a single syndrome of single P. Okay, so we will talk about these particular things, but let's first try to understand what is this 3P, 2P, and 1P. So what are the kind of organs or whatever the structures which are involved in the MEN 1 syndrome? So over here, there's involvement of parathyroid, there is involvement of pituitary, and there is involvement of the pancreas. So what are the things which are involved over here? We are going to talk about this. In the MEN 2A, what is the things which are involved? So we have parathyroid, and then what do we have? We have pheochromocytoma. And in the MEN 2B, it is again pheochromocytoma. Are you understand my point? So this is 3P, 2P, 1P, MEN 1, MEN 2A, and MEN 2B. Okay, so let's talk about the MEN 1 syndrome. Okay, so let's talk about the MEN 1 syndrome. What about this particular MEN 1 syndrome? Okay, now another important thing which you need to understand over here, all these particular syndromes are autosomal dominant. What are these? These are autosomal dominant. Okay, so MEN 1, MEN 2A, MEN 2B, all these three are autosomal dominant. So that is one thing which you need to understand. Autosomal dominant, very important. Okay, now what about this MEN 1 syndrome? MEN 1 syndrome is basically, as I told you, it is an autosomal dominant. All the three are autosomal dominant. This is basically caused by the mutation in the gene menin. Okay, so the menin, what is the gene which is involved over here? So please try to understand, menin is the gene which is involved, which is located on which chromosome number? Can anybody tell me? So this particular menin gene is located on which chromosome number? So this is basically located on chromosome number 11. Okay, so this is the one which is located on the chromosome number 11. That is what you need to understand here. Okay, now as I told you, here there is involvement of a 3P. So what are the things which are involved? Parathyroid. In the parathyroid, what might happen? So the patients may have parathyroid hyperplasia, or the patients may have parathyroid adenoma. Okay, so on the parathyroid, what you can have is parathyroid hyperplasia or parathyroid adenoma. These are the things which you need to understand. Then there is involvement of pituitary. In the pituitary, what are you going to have? In the pituitary, you can have a macroadenoma or microadenoma. Okay, and then what you can have is pancreas. Now in the pancreas, what you basically get is a pancreatic neuroendocrine tube. Okay, so what you need to get is a pancreatic neuroendocrine tube. So what you basically get is pancreatic neuroendocrine endocrine tumor. So which is the most common pancreatic neuroendocrine tumor which you basically get in the patients with the Menon syndrome? Please try to understand it is gastrinoma. Gastrinoma, which is most common. Okay, so overall, if I ask you which is the most common pancreatic neuroendocrine tumor, it is insulinoma. But if I specifically ask you in the patients with the Menon syndrome, then it is going to be the gastrinoma. So overall, what is the most common pancreatic neuroendocrine tumor? Overall, it is insulinoma. In the Menon syndrome, it is gastrinoma. I hope you have understood this particular point, guys. Yeah, got it? Now, let's talk about the MEN2A syndrome. In the MEN2A syndrome. So what did I tell you over here? MEN1, MEN2A, MEN2B, all are autosomal dominant. Okay, all are autosomal dominant. Here, what is the gene which is kind of mutated over here? So here we have a red gene. Okay, we have a red gene mutation. What you basically have over here is a red gene mutation. And where is this particular red gene mutation present? This particular red gene mutation is like this particular red gene is present on chromosome number 10. Okay, so this is basically present on the chromosome number 10. That is what you need to understand. Now, what are the things which are involved in the MEN2A syndrome? Over here, there is an involvement of parathyroid. In the parathyroid, again, what are you going to have is parathyroid hyperplasia, parathyroid hyperplasia, or adenoma. Okay, parathyroid hyperplasia or an adenoma. And what we can have is a pheochromocytoma. Pheochromocytoma. Okay, so what we can have is a parathyroid adenoma or hyperplasia and the pheochromocytoma. These are the things which you can have over here. Along with this, a very, very important thing is a medullary carcinoma of thyroid. Okay, so please do not forget this, that MEN2A and MEN2B both are the syndromes which are associated with the medullary carcinomas of the thyroid. So which thyroid malignancy is associated with the MEN2A and MEN2B? It is a medullary carcinoma of the thyroid. Okay, I hope you have understood this particular point. Okay, now let's talk about MEN2B. Okay, so now let's talk about MEN2B. Okay, so what did I tell you about the MEN2B? So over here again, as I have just told you, MEN1, MEN2A, MEN2B all are autosomal dominant in nature. What is the gene which is mutated over here? Red gene is the one which is mutated. And where is this particular red gene present? This red gene is basically located on chromosome number. This is the one which is basically located on the chromosome number 10. Okay, so this is the one which is located on the chromosome number 10. Now, what you need to understand over here, the parathyroid is not involved. So what is involved in the MEN2B syndrome? In the MEN2B syndrome, there is pheochromocytoma. There is pheochromocytoma. That is what is kind of there. And along with this, obviously, the medullary carcinoma of thyroid is also there. Medullary carcinoma of thyroid is also there. Okay, so if I give you a clinical scenario that there's a patient who is basically, I'll actually give you a clinical scenario. So I give you a clinical scenario that there is a patient who is basically having episodic hypertension, and along with this the patient had a thyroid nodule. You basically did an FNAC in this and it came out to be a medullary carcinoma of the thyroid. So essentially what the patient is basically having, episodic hypertension and medullary carcinoma of thyroid. Can you give me a diagnosis? Now, you might say that the patient is basically having a MEN2 syndrome, but how will you distinguish between MEN2A and MEN2B? So please try to understand over here. If at all they give you only this, if at all they give you episodic hypertension with the medullary carcinoma of thyroid, what are you dealing with? You are dealing with the MEN2A syndrome. But along with this, if at all they give you that the patient is having marfanoid features, okay, or and along with this, the patients are having marfanoid features, or what you call as a paragangliomas, paragangliomas, or whatever the plexiform neurofibromas, and the skin kind of a lesions are present. Then what you basically have, you have that the patient is basically having a MEN2B syndrome. Okay, so then you say that the patient is basically having a MEN2B syndrome. Are you understanding my point? So we have a MEN2A and the MEN2B. What is a MEN2A? MEN2A means episodic hypertension with the medullary carcinothyroid. In the MEN2B, what do we have? Episodic hypertension with the medullary carcinothyroid plus the marfanoid kind of features or the paragangliomas and all those particular things. So yeah, so all these particular things together, they basically constitute a MEN2B syndrome. So over here, as I told you, along with this, the patients are also going to have marfanoid features. Marfanoid features are going to be there. What else are going to be there? Paragangliomas. Paragangliomas. I hope you're able to understand this particular point, guys. Okay, so all these particular things, yeah, so that is what you need to understand. So it's a very, very important topic. I hope you've understood MEN1, MEN2A, and MEN2B syndrome, 3P, 2P, and 1P. And I hope you've understood this particular point. MEN1 syndrome, menin gene mutation, chromosome number 11, MEN2A, MEN2B, red gene mutation, chromosome number 10. Okay, I hope you've understood this point. Got it? Okay. Now, yeah, guys, so again, I just wish to kind of tell you that, what, if at all anybody has any particular doubts and after this particular session is over, if at all you're watching it in the recorded form or anything, and if at all you want to connect with me, you have any doubts or anything, this is the QR code in which you will be able to reach me on my WhatsApp. You can just drop me a text. I'll get back to you. If you wish to join me, you can join my particular YouTube channel. I will be kind of taking few sessions over here, especially if at all you're preparing for the NEET PE 2024, then you can kind of connect, because on 3rd or 4th, I'll be taking a one-shot kind of revision, probably for 6 hours. I'll kind of do that. So if at all you wish, you can kind of join that. Then this is my kind of Instagram. Again, it's very, very inactive, but within a couple of days, it's going to be really active, and I'll be posting reels and whatever the things over there. So if at all you wish, you can kind of join that. Okay, yeah. So moving on. Next topic which we have is a bed sore. Okay, so let's kind of focus on this particular bed sore. Okay, so what is a bed sore? This is what is a bed sore. Okay, yeah. So you can have this particular what you call as image like this, and this is what is basically giving you that what you are dealing with the patients with the bed sore. Okay, now let's try to talk about this. Okay, what is a risk factor for the bed sore? What is a risk factor for the development of a bed sore? Okay, so let's assume that there is a patient who is basically having a prolonged immobilization. Okay, so there's a patient who is basically having prolonged immobilization. Prolonged immobilization. When this can happen? Let's assume that there is a patient who is having a pelvic fracture, or let's say the patient has undergone some major surgery, usually an orthopedic surgery, because then the patients are not weight bearing for a prolonged period of time. Okay, so let's assume that the patients are basically, or let's say the patient is paraplegic. Okay, so if all the patients are immobilized, okay, so what happens is that the patients are dependent on caregivers. So who are these particular caregivers? Caregivers are the family members, and what you call the nursing staff. Are you understanding my point? So patients are basically dependent on them. Now, let's assume that due to some reason, if at all, there is a lack of nursing care. So what is going to happen? The patients will be, continue to stay in same position for prolonged period. Okay, so if at all there is a lack of nursing care, what is going to happen? The patients will be in the same position for a prolonged period of time. Because of this, what is going to happen? There's going to be increase in the pressure in the subcutaneous tissue. Okay, now at this point of time, you are at your home, you're watching this particular session, probably you're sitting on a chair or something like that, and I'm pretty sure after some period of time you kind of move like this and you kind of modulate the pressure and all those particular things. Why do you kind of do that? Because you want to kind of reduce the pressure which is kind of building up in your subcutaneous tissue. Now these particular patients who are prolonged immobilized, they are not at this particular liberty. They are dependent on the caregivers because they want to kind of like they're basically dependent on the caregivers. I hope you're able to understand this point. Okay, so they're dependent on these particular caregivers. Now, okay, so they are basically dependent on the caregivers. Now, if at all the caregivers do not take care of them, what is going to happen? There's going to be the increase in the pressure in this particular subcutaneous tissue. And if at all this particular pressure, like if at all this particular pressure, it rises above what you call as 30 millimeters of mercury. If at all this particular pressure rises above 30 milliliters of mercury, what is this particular 30 milliliters of mercury? This 30 milliliters of mercury is a capillary closing pressure. What is it? It is a capillary closing pressure. Okay, so if at all this particular pressure rises above this particular capillary closing pressure, what is going to happen? The blood supply to the subcutaneous tissue and the skin will be hampered. So what is going to happen? The blood supply to the subcutaneous tissue and skin is hampered. There is necrosis and there is development of a bed sore. I hope you're able to understand this particular point, guys. Okay, so this is what is the pathogenesis of the development of a bed sore. I hope you have understood this particular point, guys. Okay, so because of the lack of the nursing care, what is going to happen? The pressure is going to build up in the subcutaneous tissue, and once this particular pressure rises above this 30 milliliters of mercury, this is important, guys. So please remember, pressure above 30 milliliters of mercury, which is basically your capillary closing pressure. What is going to happen? The pressure, well, yeah, the blood supply to the subcutaneous tissue will be hampered. The skin and the subcutaneous tissue will be hampered. There's going to be the necrosis and the patients will land up into bed sore. So this is what is the pathogenesis of development of a bed sore. Okay, now I'll just like to give you a question. Okay, so depending on the stage of the bed sore, now you have to answer it. Okay, so let's assume that there is a patient and I tell you that there is a patient who is having a superficial loss of epidermis. Okay, so there's a patient who is just having a superficial loss of the epidermis. Can you please tell me what is the stage of the bed sore? What is the stage of the bed sore over here? Can you please tell me what is the stage of the bed sore? Please put your things in the comment box. So options are 1, 2, 3 and 4. Okay, so can you please help me? What is the stage of this particular bed sore? 1, 2, 3 or 4? What is the stage of the bed sore? So patient is basically having a superficial loss of the epidermis. Okay, so what is the stage of the bed sore? Stage 1. Okay, so Karan is basically saying stage 1. Anybody else, guys? Anybody else? What is the stage of this particular bed sore? Yeah, it is not 1. Okay, it is not 1. It is the stage 2. So let's try to understand about the stages of the bed sore. That's why I kind of deliberately gave you this particular question. Okay, so let's talk about the stages of bed sore. Okay, so what are the stages of the bed sore? What you need to understand is that there is stage 1. What is stage 1? Stage 1 is where there is no breach in the epidermis. There is no breach in epidermis. So what do the patients have? The patients have non-blanchable erythema. So what the patients have? Patients have a non-blanchable erythema, but there is no breach in the epidermis. Please remember this, guys. It will be very, very important. This has been asked a couple of times. So if at all they just give you that, you know what, there is non-blanchable erythema, there's no breach in the epidermis, this is what is the stage 1. What about the stage 2? In the stage 2, what do the patients have? In the stage 2, the patients have what you call as superficial loss of the epidermis. Okay, so superficial loss of epidermis. In the stage 3, what is the patient going to have? In the stage 3, there's going to be the involvement of epidermis plus the dermis. Here, there's involvement of epidermis plus dermis. Okay, so in the stage 3, there is involvement of a epidermis plus the dermis. What about the stage 4? In the stage 4, there is involvement of epidermis, dermis, as well as the subcutaneous tissue. Okay, so underlying muscles and the bones are also involved. That is what is the stage 4. So in the stage 4, entire epidermis plus the dermis plus, let's say, underlying muscles or bones. So bones are exposed, or let's say underlying subcutaneous tissue is involved. Subcutaneous tissue is involved. I hope you understood this particular point, guys. Okay, so again important is non-blanchable. Okay, so in the burns, what you basically get, in the burns we get a blanchable erythema. In the stage 1 burns, what we get is a blanchable erythema. What do we have over here? Non-blanchable erythema with no breach in the epidermis. That is what is the stage 1. Then what about the stage 2? Superficial loss of the epidermis. Stage 3 is epidermis plus the dermis. Stage 4 is epidermis, dermis plus underlying subcutaneous tissue. That is involvement of the muscles and the bones, and everything is kind of there. Okay, I hope you have understood this particular point. So this is about the stages of the bed sore which you need to understand over here. Okay, so these are the stages of the bed sore which you need to understand. Okay, understood? Got it? Now let us talk about what you call as the most common site. Okay, so if I ask you, what is the most common site of the bed sore? Can you please help me with this? What is the most common site of the bed sore? Yeah. So if I ask you, what is the most common site of the bed sore? Can you please help me with this? What is the most common site of the bed sore? Yeah. So come on, please put your answers in the comment box, guys. What is the most common site of the bed sore? Now, if at all you are answering as sacrum, probably that's not the correct answer. Okay. So the most common site of the bed sore is the ischium, guys. Okay, it's the ischium. Followed by this, what you have is a greater trochanter, and then you have the sacrum. Okay, so the most common wrong answer which we basically get is the sacrum, but please try to understand the most common site is the ischium. Ischial tuberosity is ischium. That is what is the most common kind of site of the bed sore. They have asked this quite a lot of times. So next time they might not give you ischium in the option, but if at all they give you greater trochanter, then this is going to be the answer. Are you understand my point? So ischium plus the, then second greater trochanter, followed by that is the sacrum. Sacrum is not the correct answer. The problem is that many times you have seen only this kind of an image. Okay, and then that's why you inadvertently end up marking it as a sacrum, but that's not the correct answer. Okay, now let's talk about the management. How do you manage a patient with the bed sore? Can you please help me with this? Okay, so how do you manage the patients of the bed sore? Management. How do you manage the patients with the bed sore? The management of the patients with the bed sore is what you call as, first you have to go ahead with the debridement. Okay, what you basically go is a debridement. Okay, so what you basically do is you get rid of all the dead and the necrotic tissues and everything, and after you have gotten rid of all the slough and everything, all those particular stuff, then what you basically do is, okay, so debridement you basically do. After that you basically put the patients on repeated dressings. Okay, and after that particular slough and the necrotic tissue, everything is kind of gone, then what you basically do is you have to put the patients on the vacuum assisted closure. Okay, vac dressing, vacuum assisted closure. So what is this? This is an image. So please look at this particular image. What is this? This is what is a vacuum assisted closure. Okay, what is this? This is a vacuum assisted closure. And what is a negative pressure? What is a negative pressure which is kind of generated in this particular vacuum assisted closure? The negative pressure which is generated over here is minus 125 millimeters of mercury. Okay, what is it? It is minus 125 millimeters of mercury. Okay, so the negative pressure which is generated over here is a minus 125 millimeters of mercury. Now, what is a contraindication for doing this particular vacuum assisted closure? If at all, let's say there is what you call as a slough or the necrosis. Okay, if at all there is a slough and the necrosis, that is what is a contraindication for kind of subjecting the patients to this particular vacuum assisted closure. Okay, and the negative pressure which is generated is this minus 125 millimeters of mercury. I hope you have understood this particular point. So this is one of the very, very important topics for you guys. I hope you have understood bed sore. Okay. Now, lastly, before we move ahead, how do you prevent this? Okay. So what is the prevention of the bed sore? How do you kind of prevent the bed sore? So the prevention of the bed sore is obviously a good nursing care. What is it? It is a good nursing care. So you have to kind of move the patients at repeated intervals. Okay, so how much it should be? Let's assume that you're dealing with a patient who is basically paraplegic. Patients cannot even get up. Okay, so in the paraplegic patients, you have to move them. You have to move them every 2 hours. Every 2 hours you have to kind of move these particular patients. But let's assume that the patient is bound on wheelchair. Okay, so you have to if at all the patient is basically bound on the wheelchair, then every 10 minutes the patient has to kind of lift themselves up for 10 seconds. Every 10 minutes, you have to kind of lift the patients up for around 10 seconds. That is what you need to understand if at all the patients are wheelchair bound or the patients are paraplegic. I hope you're able to understand this particular point. Okay, so this is how you kind of prevent the bed sore from formation. Another important thing is the air bed. Okay, so you can subject these particular patients to air beds. Okay, so what do these particular air beds do? Air beds again basically modulate the pressure. Okay, so because they are modulating the pressure, the chances of this particular patient is going to kind of reduce a bit. Okay, so air beds or water beds, all these particular things, but the key is that good nursing care. Okay, a good nursing care is the key for prevention of these particular beds. Okay, I hope you have understood this point. But a very, very important topic, I hope you have understood this. But do not forget about the staging. Many of you have kind of answered that a bit kind of wrong, but that's fine. Just remember the staging of the beds. Okay, now let's talk about this particular compartment syndrome. So the next topic which we have is the compartment syndrome. What is this particular compartment syndrome? Okay, so here what happens is that there is a lot of built-up of the pressure inside a compartment. So which compartment is this? Okay, what on earth is this particular compartment? Let's talk about this. Okay, so what happens is the usual scenario is going to be that there is a patient who suffered with a crush injury. Okay, so there is a patient who is suffering from a crush injury. So what do you understand by this particular crush injury? Let's assume that there was a road traffic accident. So what is this particular crush injury? There was a road traffic accident, and after the road traffic accident, let's say the car basically went over the kind of legs of this particular patient. So this is what the clinical scenario is going to be there. Okay, so there's going to be a crush injury. Crush injuries means that very, very high weight basically went over the legs or muscles and bones and everything like that. Okay, I hope you're able to understand this point. Okay, so whenever there is a patient who is suffering from a crush injury, what is going to happen? There's going to be an injury. There's going to be an injury, and what is this particular injury going to do? This particular injury is going to kind of increase the pressure in the leg compartments. The leg compartments. What is this particular leg compartment? What you need to understand over here, that what you have is you have a leg. So in between what you have a bone. So you have a bone. Okay, so okay, obviously not a very, very good kind of a thing. Okay, so what you need to understand, you have this particular bone. Okay, surrounding this particular bone, what you need to understand that there is a facial compartment. So surrounding Hello. Yeah, I'm live back. Okay. Hello, hi guys. Sorry for the issues. As I told you that there was a bit of an issue on my end. Uh, Light had gone. It has come back. So yeah, let's kind of resume the session. Sorry, a lot of disturbances today. Yeah. So what we were talking about, we were basically talking about the compartment syndrome. So what did I tell you? That you know what, there is a, like, I've just drawn a cut section in front of you. Okay, I hope you are all back over here. Yep, I hope you're all back. Okay, right. So please do come back. The session is starting. Right, that's fine. So what you need to understand is that there is a what do you call as a bone, and then what we have is we have a facial compartment. Okay, so then we have a facial compartment. Okay, inside this particular facial compartment, what we have is we have muscles. Okay, so what we have in these particular facial compartments is the muscles. Surrounding this particular facial compartment, what we have is a subcutaneous tissue. Okay, surrounding this particular facial compartment, we have the subcutaneous tissue, and surrounding this particular subcutaneous tissue, what we have is the skin. Okay, so what we have is skin which is surrounding this particular subcutaneous tissue. So this is what is the cut section of the leg, what you are basically seeing in front of you. Okay, now whenever there is a crush injury, okay, whenever there is a crush injury, what is going to happen in the crush injury? What is going to happen? There's going to be an injury to the muscles. Okay, so there's going to be the trauma or an injury to the muscles. Because of this, what is going to happen? The muscles are going to swell up. Okay, so muscles are going to swell up, but what you need to understand is that this is a fascia, and this particular fascia is a tough structure. What is it? It is a tough structure. So what you need to understand is that even though the muscles are kind of swelling up, this particular fascia is not going to give away. This particular fascia will not get distended, what you call as very, very easily. Okay. Okay, got it. So somebody is asking, crazy neurosurgeon. So class till what time and need PG aspirant? Okay, that's fine. So I completely understand crazy. So okay, your name is kind of crazy. That's fine. So the class, I think, will wrap it up by around 12 o'clock. I personally feel that it's going to wrap it up by around 12 o'clock. That's what's going to happen. Okay, I would really recommend, because of all these particular interruptions and everything, I'm happy that you're watching this, like say 15-20 days before your exam. I'm happy that I hope that I'm providing some value to you. But in order to save time, you can also watch it in the 2x as soon as this particular thing is uploaded. I think that's going to get completed by around 12 o'clock or something. 12:15 probably this particular thing is going to get completed. Okay. Yep. So yeah, let's kind of continue. So what you need to understand, the fascia is very, very tough structure. So what is going to happen, even if the muscles are kind of swollen up, what is going to happen? The fascia will not be kind of distended. And because of this, what is going to happen in this particular compartment, because the muscles are swelling up, the fascia is not getting distended. Because of this, what is going to happen? There's going to be an increase in the pressure in this particular compartment. What is going to happen? There's going to be the increase in the pressure inside this particular facial compartment. Okay, and that is what is kind of leading to this particular compartment syndrome. So I'll just kind of write it down again. Because of the crush injury, what is going to happen? That is because of the swelling and whatever the edema in the muscles, what is it going to happen? There's going to be increase in the pressure in the muscular compartment. What you need to understand is that the fascia is not going to get distended over here. The fascia is not distended, and that is why ultimately, again, if at all this particular pressure inside this particular muscle compartment, if at all it rises more than 30 millimeters of mercury, okay, if at all this particular pressure it rises more than 30 millimeters of mercury, this is what is your capillary closing pressure. Okay, what is this? This is what is your capillary closing pressure. This more than 30 milliliters of mercury. This is again here what is called as a capillary closing pressure. So this is what is your capillary closing pressure, and because of this, what is going to happen? Because of this particular, if at all it is kind of going beyond this 30 milliliters of mercury, that is what is your capillary closing pressure. What is going to happen? The muscles will get less blood supply and they are going to undergo necrosis, and because of this there's going to be the pain in the muscles. You understand my point? So the microvasculature, which is basically supplying these particular muscles, they are going to get hampered, and that is what is going to kind of cause the necrosis of the muscles, and the muscles are basically going to get tight. Okay, now when you examine these particular patients, on the clinical examination, what are you going to find? You're going to find that the distal pulsations are present. Okay, so what you need to understand over here, that the distal pulsations are still present. Okay, so what do you understand by the distal pulsations and why these particular things are present? So please try to understand. Let's assume that there is a pressure which is basically starting to rise. Okay, I'll give you a very simple example. Okay, so any particular plastic is there? Okay, so for example, let's assume that this is a plastic which I have in my hand. It's very easy to kind of bend it, right? It's very easy to kind of bend it. So the pressure which is required to kind of bend this particular plastic is very small as compared to the pressure which is basically probably required to kind of bend okay, let's assume that this particular box. Okay, so the pressure which is required to bend this particular, it will be bent. Okay, over a period of time, if at all I acquire a lot of pressure, this is going to get bent, but the pressure which is going to be needed for this, it's going to be higher. So in the similar manner, in our legs, what we have a smaller vessels, and the pressure which is required to kind of collapse these particular vessels is lesser. So if at all the pressure goes beyond this 30 milliliters of mercury, this is what is a capillary closing pressure. Small capillaries are going to get kind of collapsed, but what about the larger vessels? They are not going to get collapsed. You understand my point? Ultimately, they will get collapsed once the pressure rises way beyond, let's say 50, 60, 70. Obviously, they are going to get collapsed, but to begin with, they are not going to get collapsed. So this is why it is important